Uh, Good evening, one and all, for the Indians and for rest of the country, rest of the world. Hi, everyone. As you all know, Pure Urology is conducting on regular basis the surgical technique-based presentations in the field of urology. Today, we are discussing about the ureteroscopy and its related problems and in fact complications and in fact how to prevent them, which is more important. You know that ureter is a small tube, probably the smallest tube where endoscopy is possible. uh, e- Passing the scope through these tubes, actually they are not tubes, they are organs. What my professor used to say at PGI Chandigarh is that don't consider the ureter as tube, it is an organ, it has function, it has peristalsis, it has a neuromuscular as well as intrinsic structure for certain purpose. So if you damage any mucosa, submucosa or adventitia or muscularis, perforation, avulsion, all these are lot of consequences in the later period. In addition to that, the in day and out urology practice, whoever is doing endourology practice, you all know that it is the ureter which is commonly used for either of the ways. Even if it is for PCNL, you wanted to put ureteric catheter, supine PCNL, you want to put a flexible scope ECIRS, routine URSL, you wanted to rigid scope the flexible scope. The size of the ureter versus the scopes, they are snugly fitting as of today. Very small scopes like 3 French, 4 French are still not available. So we need certain surgical basic guidelines to deal with these small tubular structures. With this introduction, today our speaker is Dr. Kremena Petkova from Bulgaria. I was just going through her CV, very interesting academic career with nearly more than 100 publications and entire career dedicated to the endourology. We all were doing supine and ECIRS 2 years back, but Madam 2015 itself has shown a lot of interest, and I'm very happy that she is sharing the positives and negatives of the procedure as well. So with this, I like to ask about Dr. Kremena Petkova career briefly related to endourology. Good evening, madam.
Hello,
Yeah.
nice to be
So
here and thank you for the invitation.
thank you, madam, for accepting the invitation. Uh, before I introduce you and give the program, hand over the program to you, I like to know when did you develop your interest in urology, right from your medical career. What was your intention when you joined medical career?
So, my father is a neurologist, so I have
Oh,
been interested in neurology since I was a medical student. And
oh,
I like urology very much because it's not a simple surgical specialty, but it also has a lot of minimally invasive techniques such as laparoscopy and urology. And what I like in endourology is that you have to be very precise, very gentle with these operations, and there are many ways to treat different kinds of stones. So it's you have can have an individualized
uh,
strategy for every patient, and this is what raised my interest in this area of urology.
who was your earlier mentor who influenced this, apart from your father's influence, who was your mentor in your career, who made you to get into endourology stone work and then come to up to this level?
Well, I started my career in the Military Medical Academy in Sofia, Bulgaria. I was doing some internship there since I was a medical student, and Professor Saltirov was my mentor from the very first day in urology. He has very vast experience in tender urology. He actually started performing ureteroscopy and percutaneous surgery in 1985 when these techniques were introduced into the European endurologic practice. So he has an enormous experience in this area. So during my residency, I was working very close to him, and he taught me a lot of techniques, a lot of tips and tricks, and that's what we're trying to teach our residents nowadays as well.
Very good. If you do not mind, in India, out of 100 urologists, only three will be female urologists, three to five. Does it apply in European countries, or it's no more like that?
Well, when I started, there were very few women urologists in Bulgaria as well, but nowadays we have a lot of young ladies who develop interest in urology, and I believe that it's the same in Europe and in the
Yeah,
US
yeah.
also.
There's a changing trend, and it has subdivisions, subspecialties now. So lot of different specialties can attract anybody to enter the field.
Yeah.
Apart from the endourology, have you ever been into robotic laparoscopy or transplant? Any other urological procedures you were involved in your training, or you were interested, or you are practicing?
Well, we do not have a robotic program in our center, so we are just starting our laparoscopy program right now. We do a lot of urological oncology cases also. Apart from stone treatment, I'm also interested in lower end urology, lower urinary tract and urologic procedures. Unfortunately, we are not a transplant center, so we do not do any renal transplantation, but we have made steps to do so in the future. We will see how this goes. And it is unfortunate that we do not also, because we are a military hospital, we do not treat children. We have
Yeah,
another hospital for pediatric urology, so I haven't been exposed to pediatric urology as much.
yeah, yeah.
But
Yeah,
we try to go for complex treatment in
to
urology.
the yeah. So with this, I like to share the your presentation. Um, Thank you very much once again being with us. We will
Sure.
just share your CV, and then I will present the
Okay.
presentation. Okay. So I will share the screen. Sorry for that. And dear audience, as you know, today topic is video-based surgical presentation on complications from ureteroscopy and how to avoid them by Dr. Kremena Petkova from Bulgaria. Briefly, currently she is Associate Professor of Urology at the Department of Urology and Nephrology at Military Medical Academy in Sofia, Bulgaria. She has graduated and completed her residency in urology at Military Medical Academy in Sofia, Bulgaria. As Madam said, her father is also urologist. Happy to know that. She obtained a PhD degree from Military Medical Academy in Sofia, Bulgaria for her thesis on endoscopic combined intrarenal surgery in Gladaco modified supine Valdivia position for the treatment of complex urolithiasis in 2015. Her professional qualifications include multiple courses and fellowships in Bulgaria, Europe, and Asia. The professional interests are in the area of minimally invasive urology, endourology, and stone disease. She has authored more than 100 publications in Bulgarian and international scientific journals and books. She is a member of the editorial board of the Bulgarian Journal of Endourology and Minimally Invasive Surgery. She is actively participating in multiple international research and educational projects. She is taking part in the postgraduate training in endourology and urolithiasis at the Department of Urology and Nephrology at Military Medical Academy in Sofia. With this nice academic background, I am happy, and our team will be very happy to know the ureteroscopy complications and preventive aspects. Thank you very much, madam. Over to you for the program.
Thank you. Let me share my screen.
Yeah, please.
So I hope you can see my presentation
Yes,
now.
madam. Clear.
So good afternoon, everyone. Once again, I would like to thank you for the invitation to join the Pure Group. It's really a pleasure and honor for me. And during the next minutes, I will share some tips on how to avoid complications of ureteroscopy. So both ureteroscopy and shockwave lithotripsy are standard treatment options for ureteral stones, and patients should be informed that ureteroscopy has a higher complication rate compared to shockwave lithotripsy. Also, with the developments in endourology and laser technologies, the indications of ureteroscopy are increasing. And nowadays, we are able to treat even larger kidney stones, which were traditionally managed by PCNL with ureteroscopy. However, with the rising number of ureteroscopy procedures, the complication rates may also rise because we are treating now more and more complex cases. So how should we decide on the treatment method in urolithiasis? We should take into consideration some stone-related and patient-related factors, as well as some economic aspects, the availability of technical equipments, as well as surgeon's experience. URS sometimes is a very easy and straightforward procedure, but in many cases it can be very challenging because of the high probability of stone retropulsion in proximal ureteral stones, the presence of stone impaction, tortuosities and angulation of the ureter, edema and inflammation, and tight distal ureter, which may make ureteric access very challenging. Also, when we treat a high stone-free burden, the need to evacuate multiple fragments with increased operating time may pose some other challenges to the procedure. So up to date, there is no standardized classification for complications following ureteroscopy. Most of the centers use the Clavian-Dindo classification of surgical complications, and I believe that most of you are aware of the post classification proposed by the team of Professor Olivier Traxer for ureteroscopic lesions of the ureteral access sheath. Overall, the reported incidence of post-ureteroscopy complications in the literature is between 0.5 and 20%. And fortunately, the majority of complications are minor and can be managed conservatively. However, we should keep in mind that even some mild complications may have severe consequences for the patient. This is just a slide to remind you of the results of the CROWS global URS study, which shows that the rate of intraoperative and postoperative complications following ureteroscopy is low, fortunately. So which kind of complications we can encounter during ureteroscopy? Intraoperatively, we may fail to access the ureter, we may encounter some bleeding, stone retropulsion, a stuck basket, ureteral damage, loss of fragments into the retroperitoneal space, submucosal migration of fragments, some pressure-related kidney injuries, or failure of the equipment. In the postoperative period, the most common complications are ureteral obstruction and edema, urinary extravasation and urinoma, fever and infection, some bleeding, and the most feared late complication, which is ureteral stricture. So let's take a few minutes to discuss about the equipment. Although 4 or less ureteroscopies have been described in the literature, and I believe that all of us have performed ureteroscopies without the need of any fluoroscopy, I believe that having X-ray in the operating room is mandatory, especially when you're doing upper urinary tract endourology. You might not need it in uncomplicated cases, but in some complex stones and in cases where you encounter intraoperative complication, it is important to have X-rays in order to orient yourself and think how to manage the complication. Of course, radiation protection equipment for the surgical staff is a must. Light sources and good video registration systems ensure a good visualization during the procedure, and this way we can reduce the risk of complications. It is good to have different types of lithotripsy devices, such as lasers and ultrasonic lithotripters, different sizes and types of endoscopes, and of course, different disposables and working instruments, which may help you, especially in difficult cases.
Yeah.
So in our OR, we just use standard semi-rigid ureteroscopes, which are usually 8 French of size. We always have a smaller semi-rigid ureteroscope with tip size of 6 French on the back table in case we need it. We also keep different reusable and disposable flexible ureteroscopes in the OR. We have 2 digital and 1 fiber optic flexible ureteroscope. And we also always have at least 3 or 4 disposable flexible ureteroscopes in our on our back table. So access of the ureter is the first and most important step when performing ureteroscopy.
Yes.
Many risk factors may lead to failure to access the ureter. These include a tight ureteral orifice, an uncompliant ureter, presence of edema, stricture, ectopic ureters, or ureterocele. Also, a large median lobe of the prostate can preclude ureteral access. So my tips for accessing to the ureter are to always respect ureteral anatomy. It's important to never use force, and if you have any difficulties, consider drainage and a second procedure, which may be easier. Hydrophilic guide wires may also help with ureteroscopic access. Our standard technique to access the ureter is by rotating the ureteroscope from 90 to 180 degrees. This way the ureteral orifice opens and we can access the ureter with the ureteroscope. Safety guide wires are not mandatory, but are very helpful, especially in complex cases and in cases where we have intraoperative complication. The guide wire can be inserted through the ureteroscope, through a cystoscope, or with the help of a dual lumen catheter. In our center, we do not use hydrophilic guide wires as safety guide wires because they are very slippery. Instead, we prefer using a stiff guide wire with a hydrophilic tip, which we fix to the patient as shown in the video below. And we can continue with the procedure. A tight ureteral orifice is sometimes a real challenge during ureteroscopy. In these cases, we can use a smaller size ureteroscope or perform dilation, or opt for a ureteral stent for passive dilation in the ureter. In our center, when we have difficulties accessing the ureter with the smaller endoscope, we prefer to insert a Dow-J stent for passive dilation of the ureter and then plan a secondary procedure for definitive stone treatment. If the ureter is uncompliant, the railroad technique is another option. We insert 2 guide wires into the ureter and we try to maintain the maximum distance between the guide wires in order to open the ureter and gain access with the endoscope. Ureteral tortuosities and angulations can be bypassed safely with hydrophilic guide wires. As I said before, these guide wires are very slippery, so we prefer, once we gained access into the kidney with the guide wire, we prefer to load the ureteral catheter on it and exchange the guide wire with a stiff one. This way we can straighten the ureter and facilitate the access with the ureteroscope. Another tip from our center is we always perform semi-rigid ureteroscopy before flexible ureteroscopy. This step takes a few minutes, but it helps assess ureteral anatomy, the caliber of the ureter, and decide whether to use ureteral access sheet or and of which size. Also, this way we can assess the ureter for any other pathologies which were not visible on the preoperative CT scan, or remove some ureteral stones. So when performing flexible ureteroscopy, it is important to insert the ureter access sheet very gently. And if any resistance is encountered, you should consider a sheetless procedure or ureteral stent and secondary procedure. In our center, we use 11-13 French ureteral access sheets, which are enough to accommodate our endoscopes. And with this size of sheet, we have enough outflow of irrigation fluid to maintain low intrarenal pressures. We also always insert the ureteral access sheet under fluoroscopic guidance to avoid any damages of the ureter, and this way we can ensure the proper placement of the ureteral access sheet to the desired location into the ureter. Bleeding is another complication, intraoperative complication. It is rarely significant and is usually caused by the working instruments or lasers during lithotripsy. If the vision is impaired, it is better to terminate the procedure, drain the kidney, and to decide on further treatment. Fortunately, this complication may be prevented with a gentle surgical technique and fastidious use of lasers and lithotripsy devices. Stone retropulsion is more common in proximal ureteral stone. Tips to prevent this complication are to adjust laser settings according to the stone's characteristic. Usually, using a low energy, high frequency setting of the laser helps prevent stone retropulsion. You may also use anti-retropulsion devices and low pressure of the irrigation fluid. If stone retropulsion occurs, it is important not to attempt blind basketing of the stone to avoid any damages of the ureter. In our center, we usually switch to flexible ureteroscopy in order to finish the job and render the patient stone-free. However, in some cases, double J stent can be inserted and an auxiliary procedure for definitive treatment of the residual fragment plant. Another tip from our center is we usually use baskets as anti-retropulsion devices. We just entrap the stone with the basket, and we can safely perform laser lithotripsy of the stone. Of course, you can also use some dedicated anti-retropulsion devices, such as the stone cone you can see in this video. But these devices increase the cost of the procedure, so we should keep in mind this. When the basket is stuck, we had several options. What we usually do is dismantle the basket, remove the handle and the plastic cover, extract the ureteroscope, and re-entry the ureter with the ureteroscope alongside the basket to fragment the stone and extract the further extraction of fragments. Another option, if your working channel is wide enough, you can also introduce the laser fiber along the basket into the working channel and fragment the stone or cut the wires of the basket to release the stone.
Yeah.
Ureteral damage may range from superficial mucosal abrasion to perforation or even ureteral avulsion. It can be caused by endoscopes and working instruments, as well as thermal damage from lithotripsy devices. Some tips how to prevent it is to use small caliber endoscopes, Safety guide wires do not prevent ureteral damage by themselves, but they are very helpful and keep the road open in case where we encounter intraoperative ureteral damage and we need to drain the kidney with stent. You should prefer tipless nitinol baskets, which are more atraumatic compared to stainless steel baskets. Also, avoid direct contact of the lithotripsy devices with the ureteral wall and high pressures of the irrigation fluid or contrast injection. You can see on the picture on the right side of the screen, this is perforation of the ureter caused by forceful injection of contrast medium, which led to this extravasation. Sometimes the ureteroscope may feel stuck into the ureter. This may happen when we work in the proximal ureter, and the wider part of the ureteroscope is into the tight distal part of the ureter. In such cases, it is important not to force, just remove the ureteroscope very slowly and gently under direct vision in order to prevent ureteral avulsion. So superficial mucosal lesions are often seen during ureteroscopy. They can be caused by the working instruments, ureter access sheets, or lithotripsy devices. Tips to prevent it are to use the smallest sheets possible, to work gently with the disposables and working instruments, and to start lithotripsy from the center of the stone. You can see here on the video, lithotripsy was started at the periphery of the stone, and the stone is touching the mucosa of the ureter. At the end of the procedure, we have this superficial mucosal lesion. That's why this patient had a ureteral stent placed at the end of this ureteroscopy procedure. False passages can also be encountered during ureteroscopy and caused by guide wires or stents or ureteral catheters. Here is a case from our practice, which was referred to us from another hospital. This lady had a stone in the lower pole and infection. That's why our colleagues placed a DAOJ stent to drain the kidney and treat the infection. However, they did the procedure without any fluoroscopy guidance, and they also didn't check the position of the stent at the end. So when we performed the CT scan, we found that the proximal end of the stent is outside of the renal collecting system. We extracted the stent, performed ureteroscopy, and saw this small perforation. We did mini PNL on the same stage, and we placed a stent, and fortunately this injury recovered without any consequences for this lady.
Oh.
Another tip is during semi-rigid ureteroscopy, we always inspect the ureter at the end of the procedure to check for any intraoperative injuries. In flexible ureteroscopy, what we do is we remove the flexible ureteroscope together with the access sheet under direct vision. That way, while extracting the access sheet, we can check for any intraoperative injuries. Low-grade injuries we manage with ureteral stent for 2 to 4 weeks period. Lost fragments into the retroperitoneal space should not be tried to be extracted. This usually leads to further damage of the ureteral wall. In these cases, you just drain the kidney with a DAOJ stent and put the patient on antibiotics to prevent infective complications, and of course inform the patient that there are some fragments retroperitoneally, so he knows just in case any further imaging studies are made. Larger perforations may be caused by the endoscopes or the working instruments. In these cases, it is better to terminate the procedure. drain the kidney, and after that assess the situation and decide whether further surgical repair would be necessary. Ureteral avulsion is the most devastating complication. Fortunately, I have never seen it in my practice. But in these cases, the strategy is to put a nephrostomy tube and decide on immediate or stage surgical repair, depending on the case. Let's talk a little bit about impacted stones, which are a unique challenge during ureteroscopy. An impacted stone is defined as a stone that cannot be bypassed by a wire or a stone remaining in the ureter for more than 2 months. What are the challenges of impacted stones? They are usually accompanied by significant hydronephrosis, tortuosities and angulations of the ureter, and mucosal edema and inflammation. All of these may lead to failure to reach the stone and perform lithotripsy, and may increase the risk of intra and postoperative complications. So what to do when we have an impacted stone? If you cannot pass a guide wire or reach the stone with the ureteroscope, think about draining the kidney and secondary procedure. Here is a case of a lady with an impacted proximal ureteral stones. Unfortunately, neither contrast nor guide wire could be passed proximally to the stone. In addition, her distal ureter was very tight, so we couldn't reach the stone with the ureteroscope. That's why we put a nephrostomy tube in and came back for a second procedure 1 month later, which was successful. So we were able to remove both the stone and the nephrostomy tube, and the patient recovered with a ureteral stent. If the stone in the proximal ureter is not accessible with the semi-rigid ureteroscopy, we may switch to flexible. Here is a case of a young lady with a large stone just below the UPJ. We couldn't access the stone with the semi-rigid ureteroscope because of some angulation of the ureter. That's why we switched to flexible ureteroscopy, and we were able to fragment the stone and finish the procedure with a stone-free patient. Sometimes we can access the stone with the endoscope, but we are unable to pass a safety guide wire proximally to the stone. In these cases, we can start lithotripsy and pass a guide wire when this is possible. Also, we always insert ureteral stents with patients in increased risk of postoperative complications. Pressure-related kidney injury is often underestimated, especially during ureteroscopy, but it can have some very serious consequences. It may lead to urinary extravasation and urinoma, some septic complications, or bleeding because of parenchymal rupture. It is caused by either high irrigation pressure during ureteroscopy or forceful irrigation injection of contrast. So to prevent it, we should always mind the pressure of the irrigation and contrast injection. Using a ureteral access sheet may also help decrease intrarenal pressures, because with the access sheet we have outflow of irrigation fluid, and it's better to use it, especially when a longer procedure is expected. You can see on this fluoroscopy image, this was a lady in which we injected contrast with force, so she developed some pyotubular reflux. Although it doesn't look so bad in the fluoroscopy image, this patient developed sepsis in the postoperative period and had to undergo a very long treatment. Sometimes during the procedure, we may experience also failure of the equipments. To prevent damage of endoscopes, we should always be gentle and avoid excessive torque of the semi-rigid endoscope. We should try to reposition stones in more favorable calyces to avoid working with maximum deflection of the endoscope during flexible ureteroscopy. Also, do not fire the laser into the working channel of the endoscope to prevent injury to the instrument. and it is advisable to have backup equipment in the OR to be able to finish the procedure. In some cases, when backup equipment is not available, consider terminating the procedure and coming back for a second procedure. Sterilization and handling of the equipment is also a very important topic. In our center, we have a dedicated nursing staff which works only in the urology operating theater, and the nurses are very familiar with all the endoscopes and disposables and how to handle these instruments. However, in some centers, the nurses in the OR are rotating, and they are not familiar with these delicate endoscopes. So it's very important to educate your nursing staff how to take care of endoscopes and instruments in endourology. Postoperative obstruction and edema are commonly seen following ureteroscopy. They are typically self-limiting and can be managed conservatively. What we do in our center in cases which we think that the patient may experience postoperative pain due to edema, we just insert a ureteral catheter for 24 hours, which is removed on the first postoperative day. Infection and fever are also an important postoperative complication in ureteroscopy. The risk factors include female gender, preoperative infections through white stones, diabetes, impacted stones and long-lasting obstruction, and presence of drainage tubes. To prevent it, we should use antibiotic prophylaxis according to the local resistance patterns. For our center, we use single-dose second-generation cephalosporin for preoperative antibiotic prophylaxis in endourology. Also, every patient has a preoperative midstream urine culture, and we always treat urinary tract infections preoperatively. During the procedure, it's important to maintain low pressure of irrigation, use ureter access sheet when possible, and decrease operating times in order to prevent infectious complications. If the patient has a serious infection or pyonephrosis is suspected, it is better to drain the kidney with ureteral stent or nephrostomy tube and treat the infection and come back for definitive treatment of the stone. This way, we will prevent some serious septic complications for the patient. Ureteral stricture is a very serious late complication following ureteroscopy. The risk factors are trauma, ischemia, impacted stones, or intraoperative lesions of the ureter. Tips to prevent it are to be gentle during ureteroscopy, to use small caliber endoscopes, to avoid leaving fragments in the ureteral wall, and be very gentle with lithotripsy devices and working instruments. You can see on the video and the images, this is a case referred to our department for a postoperative ureteral stricture, a young gentleman who had an otherwise uneventful ureteroscopy for a 5 millimeter ureteral stone in another center. And 3 months later, he came to us with this severe ureteral stricture. We were able to perform a balloon dilation, and we inserted an allium stent, and we will see how this patient will go in the post-operative period. I think that this was a case of unrecognized intraoperative injury during the first ureteroscopy for the stone. So my take-home messages are: ureteroscopy is a safe and effective treatment option for stones in all locations. It requires skills and training in order to prevent catastrophic complications. Remember to be gentle and never force instruments to avoid iatrogenic trauma. If a complication is encountered, it is important not to panic, just stop for a minute, assess the situation, and decide on management. In difficult cases, call an experienced colleague or terminate the procedure. Remember that patient safety comes first. We should keep in mind that the ureter is a very delicate organ and its healing process following injury is unpredictable. Even some mild lesions may lead to serious and long-term complications. Adapt instruments and techniques to the individual stone and patient and not vice versa in order to achieve higher stone-free rates and lower complication rates. Also, treat complex stones in experienced and urology centers with dedicated teams. Thank you for your attention.
Thank you very much, madam. That's an excellent presentation, very crisp. I never expected so many videos you will show. Very good, and it is nice to see different aspects. Now, we will take questions for another few minutes, then we will conclude the session. First question I wanted to ask is, if you are doing ureteroscopy after 50 years, if the prostate is enlarged, ureteroscope may bend and you may not be able to see the orifice. uh, do you think the cystoscope will helpful, and the distension of bladder? What are the things where ureteric stone, if it is a kidney stone, you can abandon RIRS and you can go for mini perc, but if it is ureteric stone, you don't have choice. So my question is, enlarged prostate with ureteric stone, any tips and tricks from your side?
Well, we sometimes encounter these situations if we cannot enter the ureter with the ureteroscope. We just go in with a cystoscope, either flexible or rigid, and we try to insert a guide wire into the ureter, up into the kidney, and we try access with the semi-rigid scope on the guide wire. We try to get the endoscope between the middle lobe and the ureter in order to have a straight access into the ureteral orifice. Sometimes this is also not possible, and we cannot bend the semi-rigid ureteroscope enough in order to access the ureter. So we can consider flexible ureteroscopy in these cases. We have, last month I did a similar case. It was a very difficult case, so entrance into the ureter with the semi-rigid endoscope was impossible. So we were managed to pass a ureter access sheet up to the stone. It was a proximal ureteral stone, and we were able to finish the procedure with the flexible ureteroscope.
So accessing the ureter with the guide wire is very crucial in that case.
Yes. It makes things easier, and if you cannot gain access, you just have to terminate the procedure, put a stent, and think of another treatment option.
Yeah, it's a difficult for junior. It is a clinically difficult scenario. Better even if you stent enough and then refer to a senior or take help next time, and do not try to do, because without permission we cannot give bladder neck incision, we cannot do TURP for so that that is not acceptable. So better to get away by putting a stent if possible is the best thing. Madam, if see any of the urologist who started his career in private practice, especially 10 years back, most of them used to use 8 by 9.5 ureteroscope. Now 6 by 7.5 has actively come into picture. When we used to use the 8 by 9.5, sometimes if the ureter is narrow, the mucosa into suscept sometimes. It is not good. If you see that and suddenly you will lose the tract if you have not had a guide wire. So is it better to place guide wire in all cases before you think that the ureter is narrow, before you attempt rigid ureteroscopy, First of all, I do agree that you should not force, as you mentioned in the last slide, that never force. But it happens now and then with juniors that the mucosa will flip inside, and after that the opening you will don't see, and you really struggle, and you have to sweat out in the. This happens in the first few years of career. As you become senior, yes, quickly they put a stent and come out. What is your experience, and how do you think the junior should not do what they should not do?
Well, I have seen it and I have done it also. It happens sometimes. Juniors are supervised during endourologic procedures, and we always advise them to put a safety guide wire, even if the case seems easy or straightforward. And if the ureteral orifice seems tight, we always advise them to change to a smaller scope or call a more experienced colleague in order to prevent complications. So I think that in these cases and in the beginning of the learning curve is very important to use a safety guide wire, just to have
Yeah.
the road to the kidney open in any case.
Yes, madam. Actually, some of the senior surgeons, in relation to the small size like Kauk, Professor Kauk, they say that guide wire is no more in endoscopy. Something articles, we all feel that the Terumo guide wire helps a lot while passing the rigid or flexible scope, even in dilated ureters, even in tortuous ureters. Uh, what do you recommend? Benefit of doubt, you always pass and then get an access into the kidney, and then even in RIRS, one safety guide where sometimes if you are doing a long procedure where you are coming out, and in this guide wire outside keeps it straight and may aid in water drainage also. Do you think the same, or what do you advise in a easy case?
Well, to be honest, I don't always use a safety guide wire. It really depends on the case. If I think that the case will be more difficult, I would prefer to have a safety guide wire in place. Sometimes we have encountered during flexible ureteroscopy, we have a safety guide wire, but we cannot pass the access sheet alongside it. In these cases, we sometimes consider removing the safety guide wire and just continuing without it. So it really depends on the case, but for the young colleagues, I think it's better to use a safety guide wire just in case.
Yes, madam. Thank you. In the era of laser lithotripsy, as you all know that ureteroscopic laser lithotripsy is commonly used. You already mentioned that in the center of the stone you make fragments. Do you advise making fragments and quickly remove the fragments, or you try to dust the stone even after the fragments are made small? What is your opinion on laser lithotripsy in ureteroscopy?
Well, it depends on the type of the stone and also on the size of the stone. If some stones, such as calcium oxalate monohydrate, they are very difficult. You cannot dust such kind of stone. So in these cases, our strategy would be to fragment the stone and extract the fragments with a basket. This takes a lot of time if we have a large stone burden, so we would prefer to do so in smaller stones. In other types of stones, such as calcium oxalate dihydrate, which can be very easily dusted, this would be the preferred strategy in flexible ureteroscopy. Also, when we perform a ureteroscopy without ureteral access sheet, we don't really have the possibility to go in and out of the ureter many times. So in these cases, we would also prefer to dust the stone instead of fragmenting it. But it really depends on the size of
Yeah,
the stone, of the
depends on the
type,
clinical
and the
scenario.
location of the stone, of course.
Yeah, yeah. Do you take consent for migrated upper ureteric stone during URSL for mini perk or not? In your Do you explain the patient? It may not be possible to do RIRS because of the XYZ reason. Uh, do you ever take decision on the table to go ahead with mini perk and finish it, or you don't do it?
Well, we usually discuss the options with all the patients. They always sign a informed consent form. They during semi-rigid ureteroscopy, they also sign consent for flexible ureteroscopy. In some cases, where we believe that we might switch to PCNL, we also consent the patients preoperatively for PCNL. We have the advantage of working with spinal anesthesia in our department. So usually our patients are in the OR. They are not sleeping. They are not under general anesthesia. So we can ask them and obtain informed consent on the table. So
Yes.
it's really an advantage.
Fine. That's agreed. If the patient gives consent verbally with his mouth, then more than enough, and attendance if they say okay. Last couple of questions. What is your laser setting? You try to use less energy and less wattage in the ureter as much possible, or if the spacious ureter is there, you can use more than 10 watts. What is generally in your theater your laser settings for homium?
Well, we in our theater we have a high power holmium laser for luminis, so we have very effective lithotripsy. If the ureter is tight and we do not have much space for irrigation, we would try to use as lowest energy as possible to fragment the stone in order to prevent thermal damage to the ureter. If the ureter is wider and we have good irrigation, we would try to use higher energies in order to fragment the stone. But it also depends on the composition of the stone. If the stone is very hard, you have to use more energy to be able to fragment it.
More
And we
energy.
also have the option to switch to ultrasonic lithotripsy if we cannot do it with the laser. We sometimes do that.
Uh, if the ureter is tight and if you have decided to put the stent, generally what size you put and how many days you will wait for the re-look?
Well, it's really the size of the stent doesn't really matter in my opinion. Only in cases in which we suspect infection or pyonephrosis, we would opt for a larger ureteral stent in order to have better drainage. But in cases with tight ureters where we just need a stent for passive dilation, we would use a small stent, 5.8 or 4.8 or 5 French stent, in order to reduce also stent-related symptoms, which does not matter the size of the stent, but we have seen in our practice that patients do better with smaller size stents. And we wait 2 to 3 weeks for passive dilation to perform the secondary procedure. Unfortunately, in some ureters, passive dilation does not work in very rare cases. We
Yeah,
recently
yeah, yeah.
had such a case with a colleague of ours who had a very tight and uncompliant ureter. He had stent for 1 month and there was no change at all.
That is really frustrating,
Yeah.
especially ureteric stone. It's difficult to explain the patient why we are not able to access the ureter.
Yeah, these are
Uh,
very difficult cases.
yeah, yeah, difficult cases. In extension of the question, have you, maybe the last question in the session, have you ever tried ureteric dilatation if the patient is willing, who has come from far off and want to get the primary procedure, even if the ureter is tight, do you get tempted to do Teflon dilatation of the ureter, or balloon dilatation of the ureter, which I personally feel I do not do. I believe in stent and come back because it's very very easy to tackle the same stone except a second visit, second anesthesia, and bit cost. If you have stress of removing a small stone in especially RIRS in the kidney, the patient is generally puts pressure for single setting procedure. What is your opinion on ureteric dilatation active?
Well, I agree with you. We rarely do this in our everyday practice. We usually prefer putting a stent. That's why we always discuss this matter with the patients preoperatively, because sometimes balloon dilation may create some lesions into the ureter, which may make ureteroscopy very difficult. So we have the potential of further complications. So I would prefer to use passive dilatation of the ureter in
Okay.
99% of the cases.
Yeah. So with this, we have almost had discussion. One question from the audience. Sorry. What is your cutoff size for proximal ureteric calculus, where you try to do manage with URSL? This is question from Madhav Tiwari. Upper ureteric stone size. Do you have any criteria for URSL?
Well, we have managed even larger stones effectively with ureteroscopy, usually with stones up to 2 or 2.5 centimeters. We would try doing retrograde ureteroscopy, and it really depends on the case. If we
Yeah.
believe that we would not have a safe procedure retrogradely, we would switch to the antegrade approach. So,
That's very interesting, and some other question in different language I'm not able to understand. That's fine. We as we have reached nearly an hour of time. To be honest, 250 people have watched the program, and for all the pure urology viewers, this is a very important talk, for especially first 5 years of your into your practice. We all feel that they are minor things, but when you get struck and the guide wire doesn't go in the ureter, some of the urologists in India may not have an access to the CM also in the beginning part of practice in rural areas. So they all depend on the guide wire. If that guide wire doesn't go in the ureter, do not attempt any procedure without CM. In fact, we have not discussed about RGP, madam. Do you sometimes feel that RGP is necessary to have road? Of course, we don't do routinely, but if something is obstructing and you are not able to get an access, even RGP, like madam said, at the end of the procedure, you please have a look at the ureter. Just don't try to come out fast and do the stenting. Sometimes the RGP also will give additional clue. So we have discussed on such a common topic with all the videos covered. I really appreciate that the videos you have covered, because this is primarily surgical video based presentation. You got the point, and then thank you very much, madam, for being with us.
thank you.
I request audience to ask the questions later on also in the chat box in the same topic in the YouTube link. You can view this YouTube link